Okay, so hello everyone. My name is Sina Faraj. I'm the founding president of the Women in Surgery Interest Group Lebanon chapter, as well as the AUB chapter of the Association of Women Surgeons. It gives me great pleasure today to start this final lecture within our series of surgical lectures that have been going on since October 14th until this day. This lecture is also very special as it is a collaboration with the Walter Dandy Neurosurgical Society Lebanon Club. I hope that everyone benefited from this series as much as we did. Whoever missed any lecture can definitely check our YouTube channel, the Women Surgeons AUB, because all the lectures are uploaded there. I would also like to announce that the registration is now open for our upcoming AWS Asia Australia Regional Conference. We will be hosting leaders in the medicine and surgery, and we will be touching upon the topic of women in surgery and how healthcare leaders can contribute to bridge the gender gap. We will also talk about the Lebanese healthcare system and medical education and how we adapted to all the healthcare crises that we have faced. So, and 19. So without ado, I will go and introduce our very special speaker for today who will be ending this series for us. He has been our #1 supporter since the beginning. He is no other than Dr. Khaled Alok. Dr. Alok is the Chief Neurosurgery Resident at the American University of Beirut Medical Center. Not only is he a very talented neurosurgeon, but he's also a wonderful mentor, I can tell you that. He has been engaged in teaching first-year medical students the detailed neuroanatomy in the dissection lab, and he also taught third-year medical students the basics of neurosurgery and neuroexamination. This is a lot, I can tell you that. I hope everyone found the interesting and helpful. Today, he will be talking about neurotrauma, something that we have encountered drastically in the aftermath of the Beirut blast. Will all benefit today, so take advantage, ask on any concept that you do not fully understand, speak up, you'll use that in residency. And Dr. Alok loves students to be much engaged in his talk, so go ahead and participate even if you have to unmute yourself. I will not take any more time, so thank you everyone for joining today, and Dr. Alok, the floor is yours.
Thank you so much, Christina, for this generous introduction. Can you hear me?
Yes, we can hear you well.
Okay, that's good. I hope you can see my camera. Let me try sharing my slides.
Yes, we can see you.
Okay, that's very good. So thank you, Christina, very much for this introduction. And I would like to take this opportunity to congratulate you and the entire AWS team for this amazing project that you guys grew up from an idea throughout its infancy and until it became what it is today, a platform for lectures and international conferences. So really I congratulate you for that. You make us proud, guys. I'm waiting for my. But meanwhile, let me tell you this: when Christina first asked me to present a lecture, I was thinking, how can I present a 60 minutes lecture on WebEx or online? I mean, it's hard enough to sit through a 60 minutes in-person lecture. And personally, I find it very difficult to concentrate through any WebEx meeting. I frequently get distracted. I've slept through some meetings, to be honest. Okay, let's try this. So in my search, how can I make this beneficial and of value for all of us? I ended up finding a book, which I'm gonna show you in just a minute. The book is called Make It Stick. It's written by leaders in the psychology of education, and it's basically a bunch. It's in simple 8 chapters. It basically distills their experience and their stories about how to really learn. Because let's face it, guys, now you're sitting at home. Maybe some of you is still in the hospital. Maybe you're driving home. Maybe you're having dinner. I'm sure maybe one of you is in the toilet. And that's fine, it doesn't matter. because we live in a day and time where you have the freedom to do that, right? But with freedom comes responsibility. So it's a good idea to know how you can be in charge of your own learning so you can learn and benefit from every experience. I have my slides, but I'm still not able to share them. You can't see them yet, yeah, right? Okay. So Make It Stick is the book. I have it if someone's interested. Actually, the quiz idea came from the book, because when you try before attending a lecture, when you try recalling from memory, when you try generating answers, this boosts your memory. This makes you more ready to receive information. So that was me trying something new with you guys. Also in my slides, which unfortunately you cannot see yet, but I wanted to start this lecture by the story of a girl named Malala. You've probably read her book, you probably saw the movie. Malala is a young girl from Pakistan who was, so basically when Taliban took over the place where she used to live in Pakistan. And when Taliban took over, they prohibited girls and women from going to school and from education. Malala, however, did not accept that, and she went saying in public to local and international media that she will pursue her education in a classroom or in the street, wherever she can, and that no one has the right to prevent her or any other woman from education. Malala paid a hefty price for her courage. So she had an assassination attempt. She was shot in the head, and ironically, she had a brain trauma, and she underwent brain surgery as well. That saved her life. Malala kept on survived thanks to the neurosurgery that she underwent, and she went on to win the Nobel Peace Prize 2014. And she's still actively promoting for women education throughout the world until today. So it's appropriate to start this neurotrauma lecture talking about a woman who is an advocate for women learning. And if you're feeling down, or if you're looking if you feel like you're going through some hardship, if you're looking for an inspiration, I guarantee you that her book and the movie are really, really inspirational. Okay, so I filled the time that I can fill. Still not able to share.
The PowerPoint, and we can share them for you.
That's a good idea. I also thank the courageous among you who agreed to volunteer and to unmute themselves and participate in this discussion. So let me ask Rami Saade. Can you hear me, Rami? Okay, I'm not sure if you can. What about Abdul Majid Al Jariri? Abdul Majid, can you hear me?
Yes, doctor, I can hear you. Hello.
Hi, Abdul Majid.
Hi.
Would you like to introduce yourself?
Yes, of course. My name is Abdul Majid Al Jariri. I'm from Jordan, sixth year medical student at the Jordan University of Science and Technology. And that's it, I guess.
Welcome, Abdul Majid. We had some colleagues who graduated from your university as well. And since you are in your last year of training, Abdul Majid, what's your experience with, tell us about an experience with a patient with head trauma, someone you saw in the ER or you were involved with.
During my surgery rotation during my fourth year,
okay.
I saw a refugee from Syria who was being treated for a traumatic brain injury. It was a brief experience, to be honest, because he was not very responsive.
Okay.
But that's it.
So brain trauma is a common problem worldwide, right? What Abdelmajid saw is a war-related trauma.
I can't hear you well.
Christina, you should receive in any minutes. Let me start with so brain trauma and so trauma in general is the most common cause for morbidity and mortality for people our age. So in a young population, the most common cause for morbidity and mortality is trauma. And among trauma, brain trauma is really the worst and the reason behind most of these mortalities and morbidities. Brain trauma has been labeled as the silent epidemic because millions are affected every year. And luckily, that called for a lot of attention worldwide to try to decrease and protect from the incidence of brain damage, and how can we treat it and improve its outcome.
Again, everyone, thank you so much for sticking up till now. It's just going to be a few moments and we'll tell you the next steps. So hang on there. Okay. So the slides are up.
Perfect. Okay, so if we can please move forward. Yes, so that's the story of Malala I was telling you about. Next slide. Would you please play this small video if it's playing? So basically that was her. Yes, again, that's what we mentioned. So basically that's just a story of a woman who stood up for her right in education and she underwent neurotrauma because of it. It's me telling you guys that what we are learning today matters and can save lives. And some of these lives are gonna go on and change the world. So next slide, please. Let's jump to slide number 11. Okay, let me know when you reach number 11. Okay. So brain trauma, very common, a silent epidemic. And we can divide, so when you talk about trauma, we're talking about primary injuries, which happens at the moment of impact or the time of injury. And if we click next, we have also the secondary injuries. So primary injuries include any fracture or bleeding outside or inside the brain, whereas secondary injury involve secondary injuries, Rasha, I think Rasha is in control of the slides. I'll signal to you when just to stay coordinated. Okay. So when you have a brain trauma, you have either brain injuries that happen at the moment of impact or secondary injury that will happen later in time. So I want you to think of trauma not as an event, but rather as a series of events. They start at the moment of trauma, but they unfold over the next hours, days, and even months. And the other way to look at brain injuries is to differentiate between blunt head injuries and penetrating head injuries. when you think about blunt head trauma, is someone who has fallen, someone who hit their head against the wall or against the door. Whereas versus penetrating head trauma, which is very common in head injuries, in war injuries. During the blast, we received many penetrating head traumas. And the most common and the most frequent cause, if the next slide will show us, for blunt head trauma is ground falls. So the ground, really child or an elderly. And that problem is made worse by the prevalence of anticoagulation, so aspirin, Plavix, or all the NOACs. So you think an elderly patient come to the ER, they have fallen from the ground, but they're taking Plavix. This fall can be fatal for them. And this cool study from our engineering colleagues, they studied which kind of fall is the worst to have. So any of you who have done sports, you know, it's classic to teach how to break your fall, not to injure yourself. So they found that the first fall here in the first line, if someone who falls on their back in like a straight line without bending their hips or their knees, they're gonna hit, the head will hit the floor at around 32 kilometers per hour. So it's not, even a simple fall can cause significant injuries. Next slide, please. Okay, so I'm gonna break sections. So every time you see a picture, like the one in the next slide, that means we're transitioning from one section in the presentation to another. I would like to ask someone to help me with the next section. Maybe Dina Farah. Can you hear me, Dina? Okay, maybe not. The next slide, Pressure, please. So the next slide, the problem with brain trauma is the skull. The problem is the skull is a fixed volume space. And it's occupied by the brain tissue, by the CSF, and the blood. And that means there is no place for anything else to enter in. However, when you have a bleeding or when the brain tissue becomes swollen because of the trauma, then you have a problem because the volume is increasing, but the skull is fixed. It cannot accommodate that. So the brain had to adapt somehow. And this is the next slide, which is the famous Monroe-Kelly doctrine. So Monroe-Kelly said, those two guys back in the 1700s, they said, normally you have the brain, the CSF, and the blood, which is arterial and venous. When you start to have a mass, which is in the second line by purple color, the brain will adjust by decreasing the CSF volume and by decreasing the blood volume. And it can accommodate to a certain extent, after which it cannot accommodate anymore. Whereas the mass effect, so mass effect is a term we use repeatedly in head trauma, where the mass effect will start pushing against the brain parenchyma itself and squeezing the blood supply to a critical point where it's not enough anymore to supply the brain. So the problem is the skull is a closed box, and therefore any bleeding, even if it doesn't injure the brain, can cause problems because of the pressure. The next slide shows you how initially the brain can compensate a little bit. So you have the blue line where the brain is normal, is relaxed, everything is in its place. Then you have, the compensation gradually will decrease until it reaches a critical point, which is the red line, where it cannot accommodate the increase in volume anymore. And that's when we have problems. The next slide explains the famous coup contre coup concept. And I want you to think of the brain as a spongy tissue, very soft, that's living inside a rigid skull. So when you have an impact, like the first picture, it's transmitted to the brain and the skull differently. So the brain can actually bounce inside the skull. So not only it's hit from the side of impact, it's actually going to be hit against the skull itself on the other side. And as we're going to explain later in the lecture, wherever you have a brain trauma, you look at, okay, this is where the impact had happened. For example, this is where the fracture is. And you have to check 180 degrees and to look what happened on the other side, because that's where you'll find the counter-coup injury. The next slide, another problem of the skull, for example, when you have a penetrating injury, so here you have a bullet, it's entering the skull, injuring along its entry, then along its entire path, and then it reflects against the skull itself because it doesn't have any injury anymore to penetrate it out. It can reflect or ricochet against the skull and continue injuring the brain inside. The skull itself, that is supposed to be a protection of the brain, can in some situation becomes the coffin that kills and injure the brain. And sometimes we change that surgically to alleviate this problem, as we will see. Now, the next slide shows you that, okay, we said the skull is a box, but it's not a free box because it is divided by the dural folds. And perhaps you can remember those folds if you can name them. So you have the falx cerebri, which is the upper white arrow. So that's the falx cerebri. It's dividing the skull inside the right and left compartments. So you have the right hemisphere and the left hemisphere, everyone living on two sides of the falx. And then you have the tent. You see the tentorium cerebelli, and you can tell it's named the tent because it literally looks like a tent. And it's separate between the cerebrum on top of it and the cerebellum and the brainstem underneath it. So let's say you have a mass effect, you have a bleeding in the right compartment. The right compartment will start being pushed against the falx, and then it will be pushed toward the left side, maybe even pushed through the tentorium inside. And this gives us frequent terms that you guys hear all the time, which is when we talk about brain herniation. Brain herniation is simply a reflection of this fact that the skull is compartmentalized and one compartment is being squeezed and herniated into another. So it's just a fancy way of saying that the brain is no longer where it is no longer in place. It's being distorted, it's being pressed enough to cause damage. The next slide shows that they say a picture is better than 1,000 words. So you see here you have the red epidural hematoma on the right side, pushing the brain toward the left. So you have on the top, you have the subfalcine herniation, where the brain is herniated under the falx. Subfalcine means under the falx. And then you have the famous uncal herniation, where the uncus is pushed through the tentorium downward against the brainstem, and that's why it's dangerous. And you can see that we said the brain compensates by decreasing its CSF volume, right? Where does the CSF live? It lives in the ventricles and it lives in the sulci. So when you have a mass effect, initially the sulci will become crowded. That's the first sign of mass effect. The sulci, which normally are open and they go up and down, they become closed and crowded. And then the ventricles become smaller and distorted, like you can see in these two pictures. So these are the two initial signs of mass effect. And then you start seeing subfalcine herniation, uncal herniation. And that's when you know you have a problem. Moving on to the next slide. So now we understand some principles that make head trauma special in some way. And we're gonna move to the next slide to start talking about what to do actually when you have a head trauma patient. So the next slide, so this is the screenshot, the one we are seeing. This is from the ATLS 2018 manual. I do have the manual. If someone is interested, I can email it to you. Chapter 6 talks about head trauma. And before I move on, I want you to think, what is the most important thing to examine? Of course, my colleagues in general surgery and trauma surgery have talked about the management of head trauma and the management of trauma in general, the ABC rule, and these apply in every situation. But when you are concerned about head trauma in specific, there is a tool that we commonly use and the ATLS recommends, which the next slide will show, which is the Glasgow Coma score. Glasgow Coma score is a very simple tool. It has survived the test of time. It's been with us for decades. It's very simple and very reliable. So I advise you to memorize it by heart and to get in the habit of measuring the Glasgow Coma score, any patient who has a level of consciousness impairment. You can see that it's three sections. It starts with eyes, score of 4, then verbal response, score of 5, motor response, score of 6. So basically we have 4, 5, 6. So the way I remember that the eyes are on top, then the mouth, then the limbs and the body. So you start from up, down, you have 4, 5, and 6, right? And based on this score, we're going to divide head trauma in the next slide to 3 categories. If you have a high score between 3 and 15, that's a mild brain injury. If you have a Glasgow Coma score of 9 to 12, that's when we say we have moderate traumatic brain injury. And when you have a score between 3 and 8, that's when you have severe traumatic brain injury. Okay? So when you say mild TBI, that's synonymous with Glasgow Coma score of 3 to 15. For example, the patient is obeying commands, the patient is opening eyes to commands, this patient is confused. They don't know where they are. So if they're moving arms to command, and Rasha, if you can go back to the previous slide, if someone is obeying commands, they take 6 out of 6 for motor response. If they are opening their eyes spontaneously, they take 4 out of 4 for eye opening response. But if they are confused in their speech, they lose 1 point in the verbal response, and they have a total of 14. In a setting of trauma, that's labeled as mild traumatic brain injury. And the list goes on and on. So we examine every one of them. We get a GCS score. Then we have an algorithm for management. Now, if we go back, thank you, Rasha. You see the first line in the score is perform ABCDE with special attention to hypoxia and hypotension. So don't get distracted. Focus on you're treating the whole patient. But then when you come to managing the head trauma, we focus on these specific details. The next slide. Now you have someone who has trauma in the ER, and you see that they have a Glasgow Coma score, let's say, of 10, and you decide to investigate. The best investigation for any head trauma is CT scan. CT scan is widely available, it's relatively cheap, and it gives you a lot of information that you need in emergency situation. Please do not order skull x-rays anymore. And even if you practice in a lower resource setting, skull x-ray will not help you in a setting of trauma. It basically does not show anything. Remember, in head trauma, we're interested to see the brain, and skull x-ray simply will not show us the brain. Now, I want you to, I'm gonna throw, and Rasha, now we have a list of some points. So each clip will show a point. So I want to go over them slowly together, me and you. So thank you, those are 2 points. I'm gonna read them. GCS, so I want you to think in each situation, would you order a CT scan or not? I want you to imagine yourself, you're the physician in the ER, and you have a patient who has a Glasgow Coma score less than 13 when they arrive. So the moment they arrive to the GCS, it's 13. Would you do a CT or not? The second situation, when you have a GCS less than 15 at 2 hours after injury. So initially they were fine, then after an hour, it dropped. So it became 14 or 13 or less. Would you order a CT or not? The third situation is when you have, and I'll wait so we can read it all together. The third situation Go ahead. So the third situation is suspected open or depressed skull fracture. So if you see the bone, you can feel a deformity, you see brain tissue coming out. If you have any sign of basal skull fracture, so the signs are hematotympanium, panda eyes, CSF leakage from the ear or the nose, or a battle sign. If you have a post-traumatic seizure, if you have focal neurological deficit, or if you have more than one episode of vomiting. This slide shows if you see any of these signs in a patient, you should immediately order a CT scan. So the first one is the panda eyes. You can tell why it's called the panda eyes. Sometimes it's called raccoon eyes as well. Hematotympanium. So when you look at the eardrum, you see blood inside. Or the battle sign, which is another sign for skull-base fracture. Or like this poor guy who has CSF coming from his nose and from his ear. When you see any of these signs, you should order CT scan immediately. So again, any Glasgow Coma score below 13, any sign of skull-base fracture, or any neurological deficit should prompt an immediate CT scan. Now again, those are a few points. I would say, Rasha, go ahead, click them. Yeah. So we can, so we can get out of the delay problem. Thank you. Okay. So this group is what you should do a CT scan, but it's not as urgent. So when you have someone above 65, or you have someone with history of bleeding or clotting disorders, the same applies if someone is on antiplatelet or anticoagulation, or if the mechanism of injury is dangerous or suspicious. So if a pedestrian stuck by a motor vehicle, or a car occupant who was ejected from the motor vehicle, or a fall from a height greater than 1 meter or 5 stairs, or someone who has more than 30 minutes of retrograde amnesia immediately before the head injury. According to the NICE guidelines, and the NICE guidelines are the one adopted and made by the NHS in the UK, I recently sat for the MRCS exam. I had to read them and I found them really helpful. That's why I wanted to share them with you guys. So the NICE guidelines are telling us when you are in one of these situations, even if you have a normal exam, even if you have a Glasgow Coma score of 15, you should have a high index of suspicion that this patient might still have brain injury. If they are above 65, if they're taking antiplatelet, if they were ejected from a car, that should alert you that don't be fooled by a normal exam now. It might get worse later. Okay. So again, when you are in these situations, that's when you do a CT scan. Now, what does a CT scan? What would it show us? What are we expecting to see? So the first kind of head trauma is skull fractures, and skull fractures are classified as linear, diastatic, depressed, or sometimes they are a combination of all of these. So, for example, you see this is an autopsy of someone who had bad enough head injury. Obviously, they passed away because of it, and you can see a linear fracture, which is the big arrow in the middle, extending up to the sagittal suture. So basically, when you have linear fracture, is through the bone. Diastatic fracture, when the fracture hits the suture and the suture is split, that's when you call it a diastatic fracture. The same thing is, you can see it appreciated on the CT scan when you have a linear fracture in the bottom on the right, extending to the suture, to the sagittal suture, and splitting it apart. So we have a linear and diastatic fracture in the same patient. The next slide shows us that on normal axial CT scan, the fracture will appear as a sharp lucent line. So when you have a sharp lucent line, this is where this is how basically skull fractures appear. And one good indicator to find fracture is to look for the gallia swelling, the scalp swelling, the subgallium hematoma. You should think again of trauma in terms of process. The guy was hit on his head on the right side. Immediately at the site of impact, they have a subgallium hematoma, right? And under the impact, they have a fracture. So again, at the site of impact, you have subgallium hematoma and a fracture. The subgallium hematoma is most of the time not very important clinically, but it is a friendly sign. It's your friend because it tells you what happened. It tells you a story. It tells you the impact happened here. And then I look under the subgallia. Is there a fracture? Oh, yes, there is a fracture. But it is a linear fracture. It's only a sharp lucent line. It's not displaced or anything. So I don't care about it because the skull is just the cover. It's just a bone that's gonna heal. But what I care about, did something happen underneath this fracture? And this is what we can appreciate on the right side of the image. I know some of you guys are acquainted to CT scans. The others are not. Uh, the main point you should remember that acute bleeding on CT scan appears as white. It appears as white. We describe it in CT language as hyperdense. So let's say if I'm asked on an exam to describe the CT scan, I would say, well, the left side shows an axial CT of the brain, the bone window, and you can appreciate a linear fracture in the right frontal area with overlying subgallial hematoma and underlying convex, biconvex actually, intracranial hematoma. What would you call a biconvex intracranial hematoma? We'll see that in a few slides. But before we move on, since we're talking about CT scan, and since CT scan are very important to the concept of trauma, yes, thank you, Rashad. Have you ever heard of Hounsfield units? Well, if you haven't, Hounsfield is the British engineer who invented a CT scan. Yes, thank you, Rashad. Let's stick a little bit on this slide. So Hounsfield is the British engineer who invented the CT scan. And CT scan is only a fancy densometer. So it only measures the density of stuff. It tells you this point has a density of blah, blah, Hounsfield. This point has a density of 1,000. This point has a density of 40. And what we do when we look at CT scan, we try to figure out what does this density represent. When he invented the CT scan, to tell you a funny story, people thought that who would be interested in buying a machine that the only thing it does is to show you what's inside the box. That's exactly what it does. But then people figured out, well, the head is a closed box, and maybe we can use it to scan the head and to see the brain, and voila, now every patient, every hospital, every center has a CT scan. And people over time, they measured the density, the Hounsfield unit of every normal tissue. So they said the air is minus 1,000. The bone, on the other hand, is very dense. It's a plus 1,000. The water is the reference, it's 0. CSF is 15. Hyperdense, it's 40 to 70. Hyperdense means it's above water. Isodense, like the fat, it's minus 50 or minus 100. It's hypodense, it's less than the water. So when you describe a CT scan, you see, I see hyperdense, which means it's whiter than the water, or whiter than the CSF. You're looking at CT brain. Or you describe it as hypodense if it is darker than the CSF. And if the problem with this slide that you see, you have a density between minus 1,000 to above 1,000. How can we represent this in a sense that we can see that the human eye can appreciate? Well, the machine can start giving you numbers, but then you need algorithms and engineers to understand what's going on. So they figured, well, let's find a simpler way. Let's convert these densities to a grayscale. The problem is our eyes cannot appreciate minus 1,000 to above 1,000 scales. They cannot even appreciate 50 shades of gray, like the movie suggests. Some studies say that our eyes can barely recognize 30 shades between black and white. So how can you solve this problem? How can you project minus 1,000 to above 1,000 on a grayscale? The next slide answers this question. Have you ever heard of the word window? So bone window, brain window, lung window, parenchyma window. Basically, what we're doing, and I'll wait for the picture to illustrate it in a better way. So basically, what we're doing with the window, we're telling the machine only show me, let's say, around the level of 0, and you choose a level of the window and the width. So only show me around this number and plus or minus this certain density. Christina, do you know how old Malala is? Nobel Peace Prize winner we talked about.
Oh no, unfortunately I don't. Is she like 18? I'm just guessing a number.
Yeah, you're right. She was 17 when she won the prize. She was only 14 when she was shot. She was born in 1997. Her story is a true inspiration.
Yeah, exactly. I have heard a lot about her, so I'm looking forward to actually read more. But we've all heard, I think, about her Nobel Peace Prize and all. And it's really inspiring for everyone, like at such a young age.
Yeah, to have such a courage at such a young age. You're absolutely right. Christina, the lecture is scheduled between 7 and 8:30, right?
Yeah, we can go further. So, you guys, if you can hang around, we would really appreciate it. And so we can continue.
Okay. And for those who have other commitments or scheduled, for those who cannot stay with us, maybe they can watch it later if they want on YouTube.
Exactly. We will definitely upload all the lectures on YouTube channel.
Meanwhile, if anyone has a question, please feel free to type it in the chat. And Christina, let me take this moment to thank everybody who filled the quiz. And I'm gonna email the answers to everyone who participated, the answers and explanation for each question.
Yes, thank you very much. I actually tried your quiz before. Thank you for giving me the privilege to do it first. So I
Thank you for
really liked
volunteering.
it because it's first of all very interesting. And there are a set of different concepts where we as future neurosurgeons, like myself, would really have to know them prior to our rotation or our residency. So I think that this is not only testing our knowledge, but also it's informative and like it actually like provokes us to go and just search stuff on the internet while we are trying to solve it. So definitely, I really enjoyed solving it. So I hope everyone did as well.
But that's exactly the principle of self-learning, where it's very easy today to find the answers, but I appreciate a teacher who tells me what's important, what's not, what to look for, because then I know where to direct my energy and my focus. We have a comment from Habiba. Habiba is working on a very interesting project, a systematic review on D-dimer levels as an excellent prognostic tool for TBI. Well, the thing about brain trauma and spinal cord injury that they take a very long time to recover. So you need about 6 months to 1 year to recover from a severe traumatic brain injury. All cases are severe, obviously. Only 10% of the cases are severe traumatic brain injury, but those are the most troublesome cases because they need a lot of care and they are very expensive to care for. Malala, for example, spent months in the ICU. She had infections. She underwent multiple surgeries. So it's good to know, it's good to have a prognostic tool to know which person will improve, to be more aggressive in treating them, or who has really has no chance of improving, and then maybe you wouldn't need to put them through that much of treatment and aggressiveness. There are many tools that are being investigated. D-dimer is one of them, but as far as I know, no one of them is so far validated. I would be happy, Habiba, to answer this in specific, as it's not really our today's lecture. But if I can help in any specific question, I would be happy to.
So we have
Muhammad
a
is
few more
asking.
questions. Yeah,
Yes, would you like to read the question, Christina?
sure. So Muhammad is asking, when was the first time you knew about Malala, and has her story been a driving force for you?
I first learned about her when I started preparing this lecture. And well, you'll see from, if you see the movie, someone who has really been through a lot, really through a lot. And yet, because the movie, she is the star of the movie, she is not an actor, she is herself in the movie. And you can see someone who's just trying to live a simple life, who's living in peace despite everything she went through. She doesn't hate the people who did what they did, and she firmly believes in what she is doing. So that kind of thing is really inspiring, especially because we're not being shot exactly, but we're going through a lot this year, and all of us has to adapt with everything that's changing around. Nothing is certain anymore. Plans are becoming more difficult. Um, so yeah, I think it's nice to see. It's always nice to see a role model, someone who can impersonate those values we talk about. Has it been a driving force for me? Um, well, I'm advocating her story and inviting you guys to watch her as well. So I think, yeah, I think it has been. Is also asking about, can we depend only on CT or should we do an MRI? Well, in emergency situation, if you really want to see fractures and bleeding, that's the thing you care about, because bleeding, mass effect, those things can kill, and you need to manage them quickly. So CT scan will give you that information, it will give you what you need, and it will give it to you in short time. So someone present at 3 a.m. in the morning, you need 2 minutes, you have a CT scan. That's it. You don't, it's, whereas MRI is more sophisticated, needs special technicians, which usually don't stay 24 hours, and it takes longer period of time. It's more expensive. So usually we keep MRI for later on. So if you want to see follow-up later on, you would do an MRI, but usually not in the acute setting. You're welcome, Howard. Thank you for asking. And okay, since we have the site again, actually I will come back. So the Hounsfield unit, I hope it's clear. In the next slide, show us the concept of window, so window level and window width. So you have this fixed grayscale, and basically you're shifting this scale up and down. So that's called the level of the window. And then you are making it tighter and wider, depending on what you are looking for. Yes, so the picture that's now projecting on the slides show us an axial CT scan of the brain, bone window and brain window. The bone window, as you can see, show us the fracture clearly. It's showing the swelling up outside of it, and it's showing that there is something inside, but we cannot really tell. Whereas the brain window, the fracture is not really obvious. So that's why you need a bone window. But on the other side, this hematoma inside is now showing clearly. So you need to study both. Now, this is a patient of ours. This is a patient who was hit on the left side of his head. And I would like to say on the previous slide, Rasha, for a moment, just to show the fracture. Now, so we talked about linear fracture. Now, in this CT, we have a depressed fracture. You can see that he was hit on the side of the head. You see that this is 3D reconstruction of the CT scan. It's always nice to look at 3Ds in fractures because they kind of explain what's going on. So you can see he was hit by a metal pipe on his head, and the bone has went inside. This is what we call depressed fracture. And this is almost the only kind of fracture we care about. So linear fracture, I don't care about it. I care about the brain under the fracture. But a depressed fracture, if it's depressed more than the thickness of the skull, if it is depressed more than the thickness of the skull, then it needs repair because it can cause seizures. It can press on the brain and cause seizures. So in this case, we have a depressed skull fracture in the left temporal area, and you can see that there is a small hyperdense area under the fracture, which means there is a little bit of blood underneath. And this guy, when you decide someone needs surgery, you expose the skull, as we will show in the next slide. You expose the skull, and this is his case. So you see here's how the fracture appears in surgery. Remove the pieces, make sure the dura is not injured. It was not in this case. Then sometimes you bring some so you need to cover this hole basically, either using the fracture pieces like in the illustration. You can see they joined them together with the screws and plates, many screws and many plates, they stay inside. Or in this case, we used cement. So it's kind of powder that hardens, becomes very, very hard. So we use this powder, cement, to create a piece that basically we sutured to fill the gap, and he did very well afterward. This is a depressed skull fracture. The next slide shows us the other kind of dangerous fractures, which is open skull fracture. So this is where the skin has been disrupted, and you can tell from the CT scan that the skin is disrupted, the soft tissue are exposed, and the fracture is exposed to the outside. So skull fracture are mostly not, they tell you some brain significant trauma happened. They're not very important. I only care about what's underneath this fracture. I care about a depressed fracture and an open fracture. Otherwise, they really heal on their own. Now, the next slide. The next slide is a lovely place. It's the Acropolis in Athens, and I had the lovely idea. I had the idea of, having some of you guys with me, but we'll skip that today and maybe practice it next time before we try it. So next, we're going to talk about intracranial hemorrhages. So we have to so these are hemorrhages inside the skull itself. They can be extraaxial or intraaxial. Extraaxial, that means they are between the bone and the brain. Intraaxial means they are inside the brain itself. Extraaxial, we have epidural hematoma, subdural hematoma, traumatic subarachnoid hemorrhage, and intraaxial, we're going to talk about contusions and axonal injuries. Now, the next slide, you see this. So again, this is whenever you see a CT scan, this is a CT scan of the brain, axial cut, brain window. So those are three important definitions. And we see this hyperdense biconvex lens-shaped lesion on the left side. And you can see it's expressing mass effect on the brain. You see how the ventricles are small and they are pushed away. So that's a sign of mass effect. And this is an epidural hematoma. Why? Because it's convex in shape, because it's lens in shape. And usually epidural hematomas happen under a fracture, because a fracture injures one of the dural arteries, as you see in the illustration. The next click will show us an illustration, actually, So you have an artery here that's called the middle meningeal artery, and the fracture lacerates this artery. It can bleed, it can cause massive hematoma. And so fractures in this area, in the yellow circle area, are really dangerous because they can cause epidural hematoma, which can be fatal. The next slide shows a autopsy. So you see this is a dura-covered brain. The dura has not been removed, and yet there is a huge hematoma that's outside the dura. It's epidural, but it was so severe the person has died. It's not very common. It's potentially fatal. And I'm sure you know about the lucid interval. Because epidural hematomas does not injure the brain itself, initially the person will look okay. But as the bleeding increases, the mass effect will cause them to deteriorate. So that's why when you have suspicion, because like we said initially, suspicion because of the mechanism of injury, you should do a CT scan. Maybe there is epidural hematoma that needs evaluation. Again, it's biconvex in shape and it does not cross sutures. So those are the two characteristic features that help you to tell this is an epidural hematoma. The next slide. So epidural hematoma is one of those diseases where there is no level one evidence how to manage an epidural hematoma. And not because we don't know how to manage it, but because there was never a study on how to manage epidural hematoma, and likely there will never be a study on how to manage epidural hematoma. So epidural hematoma is an example of, if you don't have evidence, that does not mean the treatment is wrong. It's simply that we cannot generate, so there is no way, for example, to randomize epidural people, someone with epidural, should we operate you or not? There's no way to do that study. And therefore, there is no way to generate evidence. But still, the treatment is valid. So here is the recommendation from the neurosurgical recommendation is when you have an epidural hematoma greater than 30 centimeter cupid, they should be surgically evacuated. And only when it's less than 30 centimeter cupid, less than 1.5 centimeters in thickness, with less than 5 millimeter midline shift, only when these three conditions are present, where you can say, okay, I'm going to observe this. It does not need surgery. Remember, guys, we're not treating the hematoma itself, we're treating the mass effect. If a hematoma is creating enough mass effect, it needs to be treated. Treated, we mean, we're not going to go into surgical details right now, but basically, again, we open the skull, we take the blood out. That's it. Very simple if you catch it, but the trick is catch it in time. The next slide will show us the acropolis again before moving to the next type of hematoma. Yes, thank you, Amshad. So you see here on comparison, again, we have an axial on the right side and a coronal. So we call this coronal reconstruction. We have an axial and coronal CT brain, and there is a hyperdensity. This is not biconvex like the epidural. This is crescent in shape. It's like a loon. So it's crescent in shape on the surface of the brain. This is a subdural hematoma. So epidural hematoma, it's between the bone and the dura. Subdural hematoma, it's between the dura and the brain itself. Subdural hematomas, they don't have to stop at sutures because they are under the dura, but they are stopped by the folks. Remember that picture I showed you about the dural folds inside the skull? So the subdural hematoma will stop at the folks. It can go along the tent, but it does not care about the sutures. So that's how we differentiate between the two. And again, you can see, look at the coronal image here on the left side. You see how the ventricles are pushed. So the ventricles are supposed to be at the midline, but here they are pushed away all the way to the other side. So that's subfalcine herniation. And that's a sign of severe mass effect. Subdural hematomas are usually worse than epidural hematomas. Okay? And they are associated with more brain edema and they indicate worse injury most of the time. So the next slide and the next one. Okay. So they are, like we said, they are crescentic in shape. They can spread widely over the brain. They make cross-suture lines. They does not cross the forks, and they indicate worse injury than epidural hematoma. Now, the next slide will tell us that if you have a subdural hematoma greater than 1 centimeter in thickness, with midline shift more than 5 millimeter, they should be surgically evacuated. So remember, any midline shift, and by midline shift we mean if the midline structures, the folds and the ventricles, are pushed more than 5 millimeter, then you have a problem. But the next slide show us that in this case, in this particular case, the surgeons treated the person with hemicraniectomy, decompressive craniectomy. You remember that many of the problems come from the skull being a rigid, closed box. So people thought a long time ago, actually craniectomy is one of the first surgical procedures. It was performed in ancient Ancas and in ancient Egypt as well. So it's considered the first surgical procedure. They thought if we open the skull, then the box is open and the Monroe-Kelly problem is gone. And this is what was done in this case. They opened the skull, they opened the dura, they took the blood out, and they left the bone out. And you can see on the left side how the bone, you see the CT scan, there is no bone here. And a few months later, after the patient improved, after the brain edema is gone, you can put the bone back in place. Now, the next slide will show us that there are many controversies in neurosurgery that, for example, we don't know who will benefit from this procedure or not, or when should we do it, or when is it not necessary. And luckily, there are many studies going on at the moment answering these questions. One of them is Rescue ACDH. It's piloted by Cambridge. It's a multi-institutional study. They're basically trying to answer this question. If we decompress or not, if we leave the bone out or not, will this change the outcome or not? So that's similar to, at least it's along the lines that Habiba study is about. It's about how can we make this better? How can we tell who will improve and who not? So there are many studies going along these lines. Hamad is asking, how was the patient able to survive without a skull bone? Well, we don't really need the skull to survive. You know, it's just for protection. As long as no one hit he closed the skin over the brain, and that's good enough. The problem is it looks abnormal, so you lose the shape of the head. It's deforming, and that's why you replace the bone afterward. Okay. So guys, these are the two important extradural hematomas that extraaxial hematomas that we talk about. Christina, I think I will stop here. I think we've covered already a lot of material. I will open the podium for questions. See if any of the guys has any questions.
Thank you so much for this very interesting lecture. If anyone has any question, you can either type it in the chat box or you can go ahead and
Okay, I suppose either everything was clear or it was very complicated.
So if anyone does not have any more questions, we are going to go ahead and conclude this session. So basically, thank you so much, Dr. Alok, for this very interesting, and thank you everyone for sticking around. I think this concludes our surgical lecture series for this year. I hope that with this series we were able to teach you well the surgery. We will send you guys an evaluation form because we really want to listen to your opinion, what you liked and what you disliked about the series and how you want us to improve it and so on. This series actually took a lot of work of us and took a lot of preparation. We continued working on it despite everything that has been going on in Lebanon, from political to health crisis. And if I'm not mistaken, we are the first group to actually work on such a series covering major surgical topics. So a round of applause goes to my team. I really liked a sincerest thank you to my team, Rasha, who has been working on scheduling all the lectures, sending you all the emails, and doing the beautiful posters and slides. Who has been working on advertising the lectures and our social media pages. She is also the mastermind behind the Women in Surgery social media page. And she's actually working with a group of highly talented students from all over Lebanon. And of course, the rest of the team, Diane, Raya, Three Joels, Frankie, Julie, Asil, and Nahla, they have been with you every single lecture to moderate and ensure a smooth webinar. So again, thank you everyone for attending. Thank you, Dr. Alok, for ending this series for us. Thank you all for sticking up, and
Thank you, Christina. Thank you, everybody. And have a good night.